Well, so I want to back up and ask about some specific things. Like when we talked last time, use a one needle technique always. And one of the things I wanted to talk about is like when you're ablating, let's say like a relatively larger tumor, 4 or 5 centimeters, what's your technique in approaching those? And by that, I mean, if you know you can't cover it with one ablation zone, so you can pick whatever size that is, do you start from peripheral to central, or do you start central and then fan it out in different directions? I kind of want to hear about like that ablation process where you approach like larger sized tumors to still make sure you're getting margins around the tumor ablation.
So say I want to ablate a large lesion that for whatever reason might not be ideal for Y90 segmentectomy, for example. So that will be like a good example. So how do I do it? And there is plenty of data out there. I mean, mostly small series that discuss, large tumor ablations and success of ablation, even of lesions up to 8 centimeters, even in literature published by surgeons. So how can you do it? I try as much as possible not to do a 2-needle stick. If I have to do a 2-needle stick, which means start ablated, let's say, for example, the cephalad portion of the lesion and then go to a more caudal stick, I try not to. For most 4 or 5 centimeter lesions, you don't really have to. So how are you going to do it? Well, I start with, let's say a central location that would assure me a 10 millimeter coverage of its cephalad portion. So I start my ablation, just look at it like half a lesion. I'll ablate it. I'll calculate from tip to where the end ablation zone that's calculated based on the time temperature algorithm. And then I will overlap 1 to 2 centimeters. So 1 to 2 centimeter overlap backwards. In general, will accomplish full coverage of like a 4, 5, even sometimes a 6 centimeter lesion. It really depends. And then after that, if you're satisfied with your coverage, with, like I said, with a 10 millimeter, preferably with a 10 millimeter surgical margin, ablation margin. If I don't feel in a 5, 4 centimeter lesion, in general, you do not need to do a second stick. Sometimes you have to in irregularly shaped lesions, but if they're not irregularly shaped, typically you'll be able to do so. What do? You'll be it's not that difficult to pull the needle back and just move it in the 3 dimensions that you have to. If I have to move it caudal, you move it caudal and you start your second ablation. So you pull back, overlap, and then if you have to move forward, you just move forward in a more caudal fashion. Sometimes it's a more anterior, more posterior. Really, we do it in biopsies, right? With all of us, we have biopsy. You could biopsy a lesion in all type of directions. You can move within the lesion most of the time. So that's really how I accomplish full coverage, by moving in the 3 dimensions that I have to and pulling back the needle so I can accomplish an overlap of the ablation.
So it's just kind of a pullback and a redirect and then a reburn. And so my other question is, how much do you ablate? I'd like a little bit of insight is like whenever you do a redirect, so say you've already ablated, like when you think you're covering the cephalad margin of a tumor, so you pull back, redirect slightly lower, and then you want to do another ablation. How long was the first ablation? And then how long is your second and potentially third ablation if you think you need to like kind of walk that needle down?
In general, your first ablation, like I said, it really depends how shaped this tumor. Like if you are in the smaller portion of the tumor, maybe your first one is going to be a smaller ablation. But let's just pretend that it's a homogeneous lesion in all directions. It's pretty much a sphere. If it's pretty much a sphere, the first ablation is going to be your largest ablation, and then you're going to have some time to calculate what's left of the lesion. There is actually a formula. I like to give it in my presentation. There is a formula to calculate how much overlap you have to, which is basically the first sphere, the second sphere, minus the overlap zone. We're not going to go into the math of it, but it's actually pretty simple. So most of the time you have ablated. If you go to a maximal ablation, if you can ablate, let's say at 150 watts for 10 minutes, you're going to have a pretty much 4 by 4 centimeter ablation total. So if you did that for like a 3.5 lesion, you should be good. So the question is, how much do you have left? So if you have left, again, a pretty homogeneous spherical lesion, maybe you still have a 2 centimeter by 2 centimeter by 2 centimeter. So you're probably going to have, your second ablation is going to be smaller. If we're talking about a 6 centimeter lesion, question here is like, whoa, that's a big ablation. Yeah, you can do it. A lot of times we shy away from it. If the patient can tolerate it, it can be done. But those are the type of patient where the first one is going to be a 150 watts by 10 minutes, 150 watts by 10 minutes, and maybe the second one will be smaller. So it really depends. It's very hard to give, like an exact parameters.
Okay. I just didn't know if like a lot of people believe that like, you achieve a lot of your burn like in the first couple of minutes of your ablation. And so I didn't know, and I'm not going to try and pin you to it, but I didn't know if like for your subsequent ablations, you're like, really, I'm just going to go to 3 or 5 minutes. And then after that, I've achieved what I can, and I'm just going to do a redirect. Are you more likely to redirect, or are you more likely to cook it for the full 10 minutes before you reposition the needle?
I will tell you one thing. You're absolutely correct. Most of the burn is accomplished in the first ablation. However, when you pull back, you're in a completely different area that you want to cover. Obviously, it is overlapped with an area that was already burned. So my position was, guess what? With microwave ablation, you pull back the needle. You are in tumor that's still alive. You are overlapping with tumor that was ablated. What we do now is actually, if you ablate again with the same settings, you're not accomplishing anything new in that portion that was previously ablated. However, in the portion that was not ablated because you pulled back your needle, you are burning again. So you are right, but you don't really know. So I rather actually do a second good ablation that I feel good about. I have a second perfect sphere that overlaps with my first sphere, then try to exactly calculate, let me do a small, very small one that's only gonna cover the portion of the tumor that I'm pretty sure it's still alive. Because guess what? You're not really sure exactly where your ablation zone truly ended, really. I mean, you're not really 100% sure, unless, even you can't really rely on post-contrast imaging after that, and then you're making your procedure then tedious. Let's do contrast, let's try to guesstimate. So actually, I have a pretty good success with very empiric first ablation, pull back, second ablation. If I'm getting close to a pretty dicey area next to the abdominal wall or gallbladder or something that I'm starting to get concerned, that's why I start to become more conservative. And I'm like, well, this part is probably ablated, so let's do a smaller ablation that's mostly going to focus on the part that was not ablated in the first place.
Okay. Received. Message received. What's the biggest tumor you've ablated?
Good question.
Ballpark.
Yeah, I'm trying to think. I do recall a 7.5 centimeter. 7.5 centimeter that on follow-up ended up with like a 10 centimeter ablation cavity. So it was pretty large.
Okay.
When I looked at it, I thought it was pretty large. Then I saw, another colleague of mine out of Cleveland that showed me a 14 centimeter cavity ablation. And I was like, oh, okay, well, I guess mine is not that big. We started getting into, this contest of
whose ablation cavity is bigger.
Who had the biggest ablation cavity.
Okay. So it's pretty impressive.